Hi, thank you for joining us. This is Josh Kling. I'm the CEO of Newport Medical Solutions, Newport Med for short. And today we have Nilima and Brooke. They both are certified coders and are experts on coding topics for our clients. And so we're going to go through the new 2022 CPT code. We've also blended in some ICD-10 codes, all of which we think are specific. In this session, we will be recording the coding topics that are specific to orthopedics, spine surgery, pain management. So I'm going to go ahead and jump in. Brooke and Nilima, are you ready?
Yeah.
All right, here we go. I'll start this off just because I was very surprised to see that the large majority of the changes that we're going to review that are specific to our clients, most of them are editorial changes. There's not a lot of additions, deletions specific to orthopedics. Is that correct?
Yes.
So we will jump in and just look specifically at surgery, and there's only 30 new codes. So that's for all of surgery, for all the specialties. And as you'll see, there's very few for orthopedics. So we will jump into that. And Nilima, I'm going to let you go ahead and start.
Sure. So this code 1191981 is an existing code. There's been a change to the definition or the description of the code. This code can now only be used for non-biodegradable implant insertions. And for biodegradable and bioresorbable implants, they've asked us to use 17999 versus last year we were using this code for all three kinds. So that's the only difference with regards to this code. It's an existing code with just a revision and definition.
And so that 999 looks to me to be an unlisted code. Is that correct?
That's correct,
Yes.
Josh. It's an unlisted code.
So this is something that if we use this in the RCM world, we need to be prepared for a fight, right? Because
Yeah.
the insurance companies don't like to pay these unlisted codes without extra efforts.
Right. So we typically try to use a closed CPT for comparison and RVU values and add in our narration boxes as to what exactly was done to help with the payment. And if we don't get payment in the first pass, then we appeal it with all necessary records. So yes, you agreed that we have to fight for it a little bit.
All right. Well, if we're appealing it with records, we just want to recommend to all our clients that you document.
Yep.
I'm going to move on to the next slide.
Yeah. So repair, I think, again, minor changes, which we've never really, I think all of our surgeons pretty much know this, and we've been following this. Any adhesive strips, cauterizations are all included in the EM. They can't be coded separately as wound closures. And when a simple repair of the wound is done, we can use a repair code, but any hemostasis that's done in conjunction with the repair and any local anesthesia that's given is all combined in the repair code. Again, the definitions have just been expanded to clarify all this, but I think we've been doing it like this even last year. So not much change.
So essentially no changes to the way we've been working with clients and the way we code. It's just a definition change.
Right.
Adding to the definition, revising it.
Yeah, just making it clearer, I think, Josh.
Okay.
These are diagnostics code changes. We have physicians. I mean, we use low back pain quite a bit when it comes to pain management doctors and our spine surgeons. So we used to only have M for 54.5, just back pain with no other, with nothing really added to it. But now it says it's either vertebrogenic back pain or other low back pain. So it kind of differentiates between what is arising from the vertebra and what's muscular and other than arising from the vertebra. So that's the main change there. And this is something that we use pretty often. And there's new codes that is added to depict all the non-radiographic axial spondyloarthritis of the various areas of the spine, starting from cervical to the sacral area.
And this is a pretty significant expansion versus what we used to use, which was one code, right?
Right. M54.5. I think it's very important that we avoid using the 54.50 because unspecified codes are notorious for causing denials. And we should use either the 51 or 59. And again, very important for our physicians to document the source of back pain.
Now we're coming into, I think these are the ones that are relevant for spine doctors, spine surgeons, neuro and ortho. So you'll want to listen in now. Go ahead.
There've been pretty significant changes in two areas in spine surgery. It's mainly posterior fusions. The first area is posterolateral fusions. Posterior or posterolateral fusion. The earlier last year, the code was defined as per segment. So 22600 cervical, it used to be per vertebral segment. So if you're doing a C2, C3, C4, we had the chance of coding 3 vertebral segment levels. But now the definition has changed to depict an interspace. So if you're doing C2, C3, C4, there's only 2 codes because each code represents an interspace.
An interspace instead of what used to be a vertebral segment.
Vertebral segment. So there's going to be a mild dip in reimbursement because of one code going down. So for example, if we have a 3-level cervical posterolateral fusion done at C2, C3, C4, we now are going to code it as 22600. That's for C2, C3 interspace. And then 22614 for the C3, C4 interspace, versus it would have been 22600 and 22614 times 2.
Yeah.
So it'll be one less code.
And that code, and I'm just going to generalize this, that code averages right around $250. The 22614. So on a 3 level, we would be reduced about $250 per case.
Right.
Here's the big one. And so go ahead, Nilima, you've got this one nailed, and I'll share the financials right after this.
Sure. So when a laminectomy is done in a posterior interbody arthrodesis, first of all, it has to be very well documented that laminectomy is not a part of it's not being done as a part of the fusion. It has to be separately documented as it is being done for decompression. That's one major requirement to be able to code this with the fusion code. The primary fusion code will be followed by these add-on codes. So laminectomy used to have standalone codes last year, which were 63047, and add-on code would have been 63048. Now, just for posterior interbody arthrodesis, they've introduced these 2 new codes, 63052 for the first level of laminectomy, and for each additional segment, it's going to be 63053. And it has to be documented that this was done not just as a part of fusion, but for decompression.
It sure does seem like as we look at these changes that decrease revenue, it sure does seem like the AMA is not doing our specialty providers a service.
Yeah,
I agree.
All right, now here's the reimbursement comparison of what it was. We have 2021, but what it's been for all of the past that I've been in this business for the last 20 years. It's been the 63047. Which in this scenario, it's paid at 50% because it's a secondary code to the posterior fusion, correct?
right. It was a
so then the add-on codes, if we look at a 3 level, the add-on codes, we have 2 additional levels.
Right.
But this year, go ahead, Nilima, I'll let you take it from here. The new wording.
Yeah. So so laminectomy will be coded with the first add-on code. So 63052 is not a standalone code like 63047 was. So it has to follow the primary fusion code, and the reimbursement on that code is $260 versus the $550 that was on 63047.
So the AMA, because they've considered it an add-on code, they gave it 100% value, but
Right.
at a significant decrease in RVU value.
Right. And with respect to the additional laminectomies, it's not so much of a difference. So 63048 would have gotten paid, 2 levels would have gotten paid at $430, with each level at $215. And 63053 is now going to get paid 2 levels at $400, which is $200 a piece. So on the add-on code, there's not much of a reduction, but the first level of laminectomy is causing the $300 difference between last year and this year.
And so we're looking at about a $300 difference, even if it's a single level.
Right. And this is Medicare. So for commercials, we may be looking at a little higher difference based on physician contracts.
This is great information. So if you are our client, if we are your back-end RCM company, we will be monitoring this, and we'll likely be giving you as our spine surgeon client some feedback in the coming weeks. We have yet to be paid on something like this to use as an example, but this is kind of, we're letting you know. We'll monitor this and we'll give you feedback and give you a comparison, ideally EOB to EOB, so that you can see directly with your own eyes and understand for yourself. This is not a lack of performance on the back end. This is actually your wonderful AMA decreasing the value of the services that you're rendering.
Yeah.
So this one is going to be a big deal for our hand and feet surgeons, correct, Nilima?
Yeah. So I think the first manipulation, so when there is a manipulation done to reduce a fracture, and if the fracture happens to dislocate again, and when a subsequent reduction is done of the fracture or the dislocation, when the same physician is redoing it, modifier 76. Again, I think it's just a revision in the definition. We've always done this. There's very few scenarios where the provider actually does a re-reduction, but if they do it, it's codable with a modifier 76, which covers for global, and make sure that it reads as it's a procedure that is repeated by the same physician. Close treatment, I think, Josh, is what's going to make a little bit of a difference to our physicians, because anytime a patient comes into the office for a fracture and there is casting or strapping or any of those done to treat a closed fracture treatment, we could have coded these as closed treatment fracture that had a 90-day global, which is now saying you cannot treat it like a closed treatment. It has to be coded as casting, splinting, or strapping. So the patient, when they come for follow-ups in the next 90 days, each of those office visits can be billed separately versus not being able to bill if you treat it as a closed treatment. The one thing, though, that's not very clear in here is, what if the physician does not do casting, splinting, or strapping and just advises non-weight bearing for treatment of the fracture? So what do you think about that, Josh? I think we should be able to code it like closed treatment and see, because it hasn't been clearly defined.
Yeah, and so the word stabilization or stabilize is what they've really added to clarify.
Right.
Is that correct?
Right. So yeah, exactly. Yes. To temporarily stabilize the fracture, if you do a casting, splinting, or strapping, you cannot treat it as closed treatment. So we can't use the 90-day global code when any of these are being done to stabilize the fracture without manipulation.
And so,
again, too, it's the stabilization is being done solely for the patient's comfort. So that's another thing to consider as well. If it's being stabilized just for the patient's comfort, you should be doing the casting and strapping charges versus the closed treatment.
Okay, that's great clarification. I kind of overlooked that, so thank you. And is the last thing external fixation?
Again, just I think the definition has been clarified to differentiate uniplanar and multiplanar, but there's really no code changes. And I think we just code it like we've been doing it always.
Okay, great. This would be for our pain management doctors. And
yes.
So I'll let you take over.
So there's two new codes that have been introduced for thermal destruction of the intraosseous basivertebral nerves. And basivertebral nerves are the nerves that supply the vertebral end plates and cause vertebrogenic pain. So when there is vertebrogenic back pain, our pain management doctors go in and destroy these nerves. And these two codes have now been introduced to specifically depict those procedures.
And so, Nilima, what was the old code that we would have used in the past?
There was really no codes for this area, Josh. We would have probably used an RFA, like a destruction for neurolytic agent, or an unlisted, depending on which nerve was being destroyed. Okay. But now it's...
So this is great. This is new codes, more specific, that can be used to be specific to the treatment rendered, where it was probably vague in the past with just nerve destruction codes.
Right.
Great. And so for any of our clients that are providing any sort of trauma or hospital-based services where you might be on call, we just wanted to include this for you so that you can better understand these changes to the critical care. And we know that, we know that some of you are using your PAs, nurse practitioners, to do rounds with you or behind you or in front of you. So these do apply to you. So please listen up.
So concurrent care, when two practitioners, we should say, so when it's a physician and another physician, or a physician and an NP, provides care on the same day, at two different time slots to the same patient, we can add up the time to meet the first level of critical care, 99291, which is up to 74 minutes. And the additional time can be billed under the second person who's rendering the service as a standalone code for 99292. So this adding up of time has been newly introduced this year to meet the first code criteria, and then the additional time can be reported under the second physician or the NP with an add-on code 99292.
So we somewhat made sure our clients understood this in the past, that you can't bill one critical care code for the first 74 minutes that a physician sees the patient, and then later on in the day, potentially a PA is doing rounds and sees that same patient. You can't bill 99291 again. So
right.
This is further clarifying you can't do that, but what you can do is add up the time and bill accordingly.
Right. You can reach that 74 minutes by adding up the time, bill only 1 unit of 99291 per day per group, and the remaining time can be reported using 99292.
All right, great. And then the second part of this is basically reiterating how it should be billed.
Right, Josh. Just adding up the time. How do you reach the 74 minutes and the remaining time be reported under another physician?
Great. And this is further clarifying splitting services and the rules for doing so.
Right. Split or shared services, typically, I think these get done when an NP or a PA is rounding on the patient and then is following up with the physician, calling the physician, updating all the lab values, the patient status, and then the physician is probably reviewing images. So there's time spent by both of them. So if the NP and the physician are spending, say, 10, 15 minutes talking about the patient on phone or directly, that 10, 15 minutes can be counted only once. We can double count that time. And it has to be billed under the physician that spends the most time with the patient. But critical care it's not only defined as what is spent at the bedside. It's time that's spent at the bedside, time spent reviewing the labs, time spent coordinating with other specialties, time spent counseling the caregivers, all of that time. So this time can now be added up, billed under one of those providers, either the NP or the doctor. Typically, split and shared services don't happen between two providers. It's usually an NP or a PA and a physician. So it's being defined as it should be billed under the person that spends the most time. So that is important to be documented when they
I
dictate
think
it.
it's also important, Lima, that we note to the listeners that that's a CMS requirement, right? Where
Right.
in some cases, we get some of our commercial carriers that don't recognize a PA or an MP. And
Right.
in this case, it's billed under the physician.
Under the physician. And even with CMS, when they say substantive portion of the service or the most amount of time, there's also another clause saying decision making, like whoever does decision making can bill for the service. So I think that gives an advantage to the MD there. But it's very important to document all of that and the time spent to be able to bill this correctly.
Great. Okay. So these are new codes, and we don't know what of our specialties, because these seem to be emerging codes as far as what technology allows. And so these are new codes for therapeutic monitoring of some form or fashion.
Right.
I'm going to move on to the next slide, because this tends to add additional language and additional understanding of these new codes.
Yeah, so 98975, that series through 98977 is any remote therapeutic monitoring. Just the first code is just the setup and patient education on use of the equipment and all of that. And the remaining two codes are add-on codes for the monitoring and the supply. The other series, which is 98980 and 98981, is management of those remote monitoring services, which is actual time spent discussing the monitoring. So the first 20 minutes is 98980, and each additional 20 minutes is 98981.
And Nilima, I noticed it says for those codes, other qualified healthcare professionals. So that could be the physician, that could be a PA, or that could be an MA that's working on behalf of the physician, correct?
That's correct, Josh. And the other important thing I think here is we've been using with some of our clients, orthopedic clients, we've been using 99453 for remote monitoring services. 99453 was more generic in monitoring, things like blood pressure and pulse ox. But this code is more specific to musculoskeletal system status, which is more relevant to our ortho surgeons. We can switch from 99453 to 98975.
Yeah, great. And this is just further, correct me if I'm wrong, Brooke and Nilima, this seems to be like the AMA, the CPT manual is catching up to the guidelines given during the pandemic as far as the services rendered via telehealth.
Yes.
Am I right in that assumption?
Yes. Appendix P will just list everything that is now can be used as telehealth. But throughout the CPT book in general, you'll see that star out to the side representing that it can be used for telemedicine.
Okay, and so I see 99211 here. I don't see 99212 through 215, or those codes can still be used via telehealth or telemedicine, right?
Yes.
Yes.
This is just adding that 99211 to the list.
Correct.
All right, great. All right, that's the conclusion. We are here for you. Nilima and Brooke and the rest of the coding team are happy to answer any questions, do a deep dive on any concerns, anything that we haven't addressed here. Just email us at coding@newportmed.com and we will get you a response as soon as possible. Just know that if you don't get a response immediately, that's because we are doing homework and research in order to adequately respond. We don't want to respond with an assumption. We want to respond as clearly and accurately as possible. Thank you very much for joining us today, and we look forward to serving you and talking to you in the future.
Thank you.
Thank you.